Good evening, everyone. Thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants. As moderator this evening, we have Dr. Firas Hougier, Clinical Assistant Professor, Department of Internal Medicine, Philadelphia College of Osteopathic Medicine, President of Southeast Dermatology Specialists. As speaker this evening, we have Dr. Stephen Daveluy, Associate Professor and Program Director, Wayne State University in Detroit, Windsor, Ontario, Canada. The title of tonight's program is The Latest Improved Indication for COSENTYX. We'd like to thank our supporter this evening, Novartis, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having any technical issues, please submit a question in the question pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your browser, but it will also be emailed to you in 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. And then finally, within 1 to 2 days of the webinar, a certificate of attendance will also be emailed to you. Again, we will have a Q&A portion at the end of the program, so if you have any questions, you're welcome to enter them into the question pane at any time, and we will get to them at the end. Without further ado, I would like to pass the floor virtually to Dr. Hougier.
Hello, good evening, everybody. Thank you for joining us today for another IDEF webinar and seminar. I see that it's another successful one with many of you guys, already over 400 of you guys on the line. Today we have a special treat for our presentation. And again, this presentation is brought to you by the IDEF, the International Dermatology Education Foundation. This is a nonprofit organization that was founded by Dr. Leon Kircik. The principal mission of this organization is to raise awareness and improve dermatology care all over the world through education, and especially in underserved areas. Many previous educational sessions were done and were accomplished through this organization. We had educational series including very well-known thought leaders and very well-known dermatologists in our community and throughout the world. Today, we have the distinct pleasure of having Dr. Stephen Daveluy discuss with us the latest approved indication for secukinumab, COSENTYX, which is hidradenitis suppurativa. Dr. Daveluy is an associate professor and program director at Wayne State University in Detroit, Michigan. He, however, lives across the border in Canada. He earned his bachelor's in science from Michigan State University, completed medical school and residency at Wayne State University. He does hold a special interest in teledermatology, non-invasive skin imaging, integrative dermatology, and complex medical dermatology, including hidradenitis suppurativa. So without further ado, I will give the word to Dr. Daveluy, who will give us a great presentation today.
Thank you so much for the kind intro, and it really is an honor to be speaking to the IDEF, and I'm so thrilled that so many people are in attendance, and I get to speak about one of my passions, which is, of course, hidradenitis suppurativa. It's a really exciting time because we have a new medication. It is the first and only IL-17 inhibitor approved, and it's just a really great time to now be seeing more options for our patients with HS. So here's kind of an overview of the things that we'll talk about today and run through, and we'll start off with our patient burden. And I probably don't need to belabor these points too much because we know a lot of the challenges that we face with HS. It's understudied, underdiagnosed, and undertreated. We think the prevalence is about 1 in 100 people worldwide. It's really hard to do our prevalence studies in HS because we know that there's that 7 to 10 year delay in diagnosis. So there's a lot of people out there undiagnosed, and there might be a lot of people that we're missing with diagnosis. And that's some of the challenges we see in doing our epidemiologic studies with HS. We know it's a chronic systemic inflammatory condition where patients get these recurrent painful nodules, abscesses, and tunnels in their skin. And we know that it causes irreversible skin damage, scarring, and pain, which can really be a big burden for our patients. And about 97% experience pain. And we know pain is really the cardinal symptom in HS. It's really the thing that drives patients to seek care. And I'll just mention also that the irreversible skin damage is really one of the things that's sort of unique with HS. I think we know in psoriasis, no matter how bad your psoriasis gets, I can reverse it and get you back to normal skin. But with HS, as that damage happens, there's a progression where I can't reverse it. I can't get it to go back to normal, which is why it really underscores the importance of earlier diagnosis. We want to stop those tunnels and scarring because we think earlier treatment can prevent that progression, maybe prevent surgery, and definitely decrease that burden that patients see and improve outcomes. So we want to make sure we're getting that diagnosis early, which is why it's so great that we're doing a good job of spreading the word and teaching our colleagues and raising awareness, and then get treatments started early to stop that damage from happening. So help your patients with the newest medication approved for HS, COSENTYX or secukinumab. It's approved for adults with moderate to severe HS. So let's talk about COSENTYX a little bit. It's not new. We're used to it. We have experience with COSENTYX. So let's talk a little bit about the heritage that we see. So we have over 16 years of clinical trial data experience, and it's been on the market for over 8 years. And there's been about 3.7 million prescriptions just within the US. And of course, there are patient support programs to help onboard patients and assist patients to get started, because we know that sometimes that can be a challenge, the insurance hurdles for approval, and then, training patients how to do injections, kind of holding their hands a little bit. But we've got a lot of experience with it, and Novartis has a good track record of helping patients to get access and to get their on medication to know how to handle it. So it was first approved for moderate to severe plaque psoriasis in 2015. Then a year later, they added psoriatic arthritis and ankylosing spondylitis. And then they added spondyloarthritis, plaque psoriasis in pediatric patients down to the age of 6. And then enthesitis-related arthritis in peds down to 4. And juvenile psoriatic arthritis down to age 2. So the youngest age approval right now across indications is 2 years old, which I'm always reassured to see data in younger patients with our biologics, because it's just kind of reassuring if you can tell patients who are a little bit more nervous that, hey, this is approved down to age 2. That's always kind of a reassuring thing. But for hidradenitis suppurativa, it is right now approved for 18 and older. So in 2023, just in October, it was approved. It's the first and only IL-17 alpha antagonist for adults with moderate to severe HS. So let's talk a little bit about how it works and the pathophysiology of HS, which is sort of a concept that we're still learning about and understanding. We do know from some of our basic science studies that when we sample both lesional HS skin and perilesional, so adjacent skin that appears normal but is still adjacent to the HS, that IL-17 alpha is elevated in those tissues. So we know that the HS lesions themselves are triggering the release of this IL-17, and it's diffusing out into the tissue surrounding it. And these elevated levels are also driving changes that are happening in inflammation and sort of driving this disease process. So this is sort of a zoom in on some lesional skin and some of our pathophysiology diagrams that we're sort of used to seeing. So we still think that follicular hyperkeratosis is one of the early stages of HS. We still don't understand why things like a topical retinoid that in theory would keep this from happening don't work really well in HS. So there's more to the picture. We still think this is an early event in the pathogenesis based on some of our histopathology and ultrasound studies that we've done. That leads to occlusion, and then it starts this inflammatory process and possibly bacterial overgrowth and abnormal colonization. Then the hair follicle ruptures, and that activates more immune cells because now there's all these substances that shouldn't be in the dermis and are in the dermis. So it starts that inflammatory cascade. And then this picture depicts where these ruptured follicles start to sort of interconnect and form tunnels, and it's chronic inflammatory state that causes the scarring and the tunnels. And we also have research now that shows that these tunnels are actually one of the sources of inflammation. So that's one of the interesting things with HS is we think that some of the inflammatory drivers actually change as the disease evolves, and that may be why certain treatments may work in some states but not in others, and why disease can become harder to treat is because you now have this new source of immunologic stimulus or inflammatory stimulus in the tunnels themselves. So taking a little bit closer look, COSENTYX selectively binds to IL-17A and inhibits its interaction with the receptor. So if you look, this is our COSENTYX here, kind of binding, it's the big pink guy binding to that IL-17, which is our orange little cylinder sort of thing floating around down there. So we believe that that is how it can help with the signs and symptoms and lead to improvement in HS, is because it blocks this IL-17 pathway by binding to that IL-17, preventing it from binding to receptors in the JAK-STAT pathway and leading to continued inflammation and inflammatory changes. So you can see it's binding up the tissue IL-17 and the circulating IL-17 to stop that interaction from happening. So how well does it work for HS? The two pivotal trials that got approval for COSENTYX are called Sunrise and Sunshine. It's the largest ever phase 3 trial for HS with over 1,000 patients. Well, so that's really great news, because the more patients you have in a trial, the more robust your results will be. So together we call them, because they're Sunrise and Sunshine, the Sunny trials. They were phase 3 randomized controlled double-blind multi-center studies from across the world, and they looked at 16 weeks for the primary endpoint, but then carried out through a year. At 16 weeks you just take people off placebo, and then you're looking at both the efficacy and the safety of COSENTYX in adults with moderate to severe HS. So you can see the Sunshine trial on the left and the distribution of countries included, and Sunrise on the right. So we really had global representation throughout the, both of the trials, with both over 500 patients each, getting us to that number of over 1,000 total. So patients had to be at least 18. They had to have at least 5 inflammatory lesions. And we'll talk about that, because if you're familiar with the HiSCR, which is sort of our clinical trial tool, you know that that's what we're looking at, is these abscesses and nodules and counting them. The lesions had to involve at least 2 distinct anatomic areas, so you couldn't just have one axilla involved. And then they had to have a diagnosis for at least 1 year prior to their baseline visit for the trial. And then stable treatment with tetracycline class antibiotics were allowed, or previous treatment with a TNF inhibitor was also allowed. And that's an important point, because that sort of reflects some of our real world questions we ask ourselves. You know, if a patient has failed one treatment, do we have data that shows that this treatment could still work in them? And especially as we get more treatment options, that's something that we ask ourselves, and it's an important thing that our patients ask us too. In terms of exclusion criteria, you couldn't be in the trial if you had more than 20 fistulas. So unfortunately, that means our most severe patients aren't eligible. But part of the reason is because those severe patients may not be able to show as robust a response to medical therapy. You know, sort of the paradigm for HS, at least in the later stages, is that it's a combination of medical and surgical therapy. And so including patients in the trial who really need to have some surgical interventions may damage your results, in the sense that you can't show how well it works in those really severe cases that monotherapy just isn't going to work for them. You couldn't have another skin disease that would obscure your observations of the HS, so you couldn't have any kind of major rashes or psoriasis in your armpits, because that would make assessment too difficult. And then you couldn't have ongoing inflammatory diseases, including inflammatory bowel disease, or previous exposure to a biologic that blocked IL-17A or AF or the receptor. So no prior IL-17 exposure, but prior TNF alpha inhibitor exposure was allowed. This diagram demonstrates that study design. So the patients were either randomized into the placebo group, COSENTYX 300 milligrams every 4 weeks, which is the typical psoriasis dosing that we're used to, or COSENTYX every 2 weeks. Both the COSENTYX groups had the typical 5-week induction dosing, and then they either went to the Q2 weeks or the Q4 weeks, and that was carried through week 16. And at week 16, the primary endpoint was the HiSCR, or now we sometimes call it the HiSCR 50. But there were also secondary endpoints at week 16, which included the AN50, or abscess and inflammatory nodule count, which is similar to the HiSCR, but I'll kind of highlight the difference in a minute. and the proportion of patients who are having HS flares, and we'll talk about that as well. And then we also looked at pain, because as we mentioned, pain is really the cardinal symptom of an HS. And we always think that, the first step in treating the pain is, of course, to treat the disease itself, because that will help to reduce the pain. But if your patients are like mine, they often actually ask, well, how much will this help my pain? So it is nice to have some data to specifically address patients' pain, and that was one of the secondary endpoints, and we looked for improvement in the pain. Then after that 16-week period, they extended the trial out for a full year. So if you were on COSENTYX, you remained on the dose you were already on. If you were in placebo, you got re-randomized to either the Q2 week or Q4 week dosing, and you got the induction dosing again. So an important thing to do is not keep people on placebo for a full year, because that would just be cruel, especially to an HS patient where we know the disease can progress, and you can't just keep someone on placebo. It's unethical. So they got re-randomized to actually be in one of the treatment groups. So this is looking at the endpoints that they looked at 1 year. So after the 16-week period and out to the 52-week period, they looked at the high score or high score 50, high score 75, which means 75 improvement in the score, high score 90 and high score 100. Again, that abscess and nodule count, the flares, and the NRS 30, which is that pain scale. And then also the Dermatology Life Quality Index, or DLQI, which is one of the tools we use in clinical trials to measure how much their disease has an impact on their quality of life. This shows our baseline characteristics across all three groups, the COSENTYX Q4 weeks, 2 weeks of placebo for both Sunrise and Sunshine. You can see most patients were under 40, with the median age was about 37. Just over half of patients were female, and we know that this is a female-predominated disease. In the US and in the Western world, it's typically 3 females to every 1 male patient. So this number's up a little lower than that, but interestingly, that demographic is for the Western world. But in the Eastern part of the world, especially in some Asian countries, the demographic is actually flipped, and HS is more common in men than women. We don't fully understand why, but having a global trial is then why it might not reflect the numbers that we're exactly used to. As you can see, more than 50% of patients had a weight of over 90 kilograms. And we know that obesity is associated with HS. We don't really know chicken or the egg, but we know that that is representative of the patients that we see. And then you can see the racial distribution with the majority Caucasian, but also a significant number of African American and Asian patients included in the trial. In terms of Hurley stage, patients with Hurley stage 2 or 3 were included. They actually did have some Hurley stage 1 patients who were able to be classified as moderate to severe based on other metrics such as their pain scores. And I think that's something that's important. Is I always try to tell people, don't always consider Hurley stage 1, 2, 3 mild, moderate, severe, because you can have a moderate to severe patient who's Hurley stage 1 or 2, but they're still having a lot of pain, a lot of symptoms. The symptoms are frequent, and sometimes that gets confusing for our patients, because we know our HS patients read a lot online. They're pretty tech savvy. A lot of them make their own diagnosis. They go to the internet to find things. So sometimes they might ask their Hurley stage, and I always kind of have a brief discussion with them about the Hurley stage as sort of a way to measure how much tissue damage has been done and if you're a candidate for surgery, but it doesn't necessarily mean that your Hurley stage 2 is less severe than someone with Hurley stage 3. So just an important thing to note. And you can see the distribution was more Hurley stage 2 patients than Hurley stage 3, which sort of fits the demographics that we see. And you can see a significant number of the patients did have prior surgery. So they weren't excluded from the trial if they had had surgery, but they still needed to meet the other inclusion criteria. And then around 25% had prior exposure to an anti-TNF biologic, which was really great when the trial was recruiting, because I think, when you have patients on a medication and they're not doing so well and the trials are out there, it's nice when they aren't excluded and they have a new option. Those are the patients you're sort of waiting for the next thing. And then a majority of patients had exposure to a systemic antibiotic, because that's sort of typical of HS patients. And then, as I mentioned, about 24% were previously on an anti-TNF biologic, which is a good thing for us to be equipped with that data, because that's some of the patients who are sort of looking for that next treatment. So this shows the 16-week data for the Q4 week arm, which is sort of that psoriasis dosing that we're used to. And this is for the HiSCR 50. So the bottom box kind of shows you there, what does HiSCR mean? It's a 50% or greater reduction in abscesses and inflammatory nodules compared to their baseline. So it's a binary outcome. You either are a HiSCR 50 responder or you're not if you have that 50% reduction. But there's also no increase in the number of abscesses and no increase in the number of draining fistulas. And the reason those are part of the HiSCR is because we wanted to make sure that it wasn't that patients' lesions were just turning into tunnels or nodules were sort of turning into abscesses, sort of other signs that they might be sort of still flaring or progressing, especially turning into tunnels. You didn't want, well, your number of lesions went down, but it's because 3 abscesses joined together and formed a tunnel. So that's sort of like a backup to make sure that we're really measuring improvement and reduction, is that you're not just converting into tunnels. And so you can see 41.3% and 42.5% of patients on in the treatment group achieved that HiSCR 50 response. And here is that HiSCR 50 shown as a graph. So this is at 16 weeks. We can see the placebo, the 2 like grayish colored ones that are lower down, hitting 32 and 35% are the placebo. And then the COSENTYX Q2 and Q4 weeks are the 45.2 and 44.8 at week 16, achieving that HiSCR. And that was a statistically significant difference between treatment and placebo. One of the challenges we have with HS trials is that our placebo rates are actually pretty high, and we don't fully understand why. We think part of it is that it's a disease that kind of goes up and down. I'm sure if you're like me, you've had patients who say, I'd look really good today, but it was just flaring up and it's been doing terrible, or the opposite. I'm happy with my treatment, but it just looks bad today. I'm just having a flare up. So that may be part of it. We also don't know if there's a little bit of a boost to the placebo, because we know that patients with HS often feel really hopeless. They've seen a lot of doctors who don't know what they have. They've had a lot of treatments that didn't work. They sort of lose confidence in the medical system. So then entering a clinical trial where someone not only knows what you have, they're paying a lot of attention to you, they're offering you a treatment that might help, can offer a lot of hope to patients. So that may also sort of help that stress-induced flaring and sort of decrease their or increase their cortisol levels, kind of calm things down. So we don't really know, but we know it's a challenge with our HS trials. And that's why it's really great that we had a large number of patients, because the higher your placebo rate, the more patients you need in a trial to be able to demonstrate that significant improvement. And then, as I said, they extended out to 52 weeks. So here's that 52-week data. And you can see now where those placebo patients swapped over to either the Q2 weeks or the Q4 weeks. So this is across both the Sinai trials. What did those rates look like at week 52? And we can see it's a sustained effect. It maintains as patients go out. And there was no difference between patients who had a previous TNF exposure and patients who didn't, which is a nice thing to tell patients, that there's no signs that because one didn't work, COSENTYX isn't going to work. Now, because of the way the trial is designed, you can't do any statistical calculations at week 52 because you don't have a placebo group to compare to anymore. So this is as observed data, but I think it's still very useful because this is sort of clinical practice. If you have a patient that you're going to keep on drug because you're seeing improvement and you're seeing response, are they going to be able to maintain that response? So it's something that patients wonder about, and it's nice to be able to tell them. And then 83% of patients on COSENTYX didn't have any new draining tunnels at 1 year. So again, that sort of speaks to this disease progression. To say they didn't form any new tunnels is great, because that's what we really want to do. We want to halt that progression, because that's going to be a need for surgery. Again, you can't do statistical analysis on that, but it's still a valuable number to have and to look at. And this is those exploratory endpoints, the HiSCR 75, 90, and 100. So the HiSCR is a 50% improvement in your abscess nodule count. The 75, 90, and 100 is a 75, 90, and 100% improvement. So we can see our HiSCR 75s for Sunrise and Sunshine. These are the improvements in high score response at 1 year in patients who got the high score 50 at week 16. So if at week 16 you were responding and you stayed on medication, what did things look like at 1 year? So we can see of those patients, 62 to 65% hit that 75 marker, because the high score 50 is that binary endpoint. Did you get 50% improvement or not? Some of these patients actually did better. And so same thing with the high score 90 at 1 year. We're seeing a third to over a third are hitting that 90. And we even have around 25%, 24 to 35% are achieving 100%. They're completely under control. So it's nice to let patients know that some people do have a really good response and get complete control of their disease with this medication. And then let's talk a little bit about helping your patient. The COSENTYX can help your patients get that lasting relief at 16 weeks. We saw the fast results as early as week 2. So we actually had data that some of these patients were seeing that high score 50 at week 2, which is just fantastic. Again, we didn't make statistical comparisons at that point, but it is interesting to be able to tell patients. And I think we know from psoriasis that IL-17s work quickly for patients. So it's good to know that that sort of translates over to some of our HS patients as well. So this is a graphic. It's not an actual patient. It's sort of a computer representation of HS. And this shows what a 50% reduction can look like, or an AN count 50% reduction. So this AN 50 is a different measure. And I know you're thinking it sounds just like the high score. So the difference with the AN 50 is that it doesn't have that those 2 extra qualifiers of no new draining tunnels and no new abscesses. The no new draining tunnels is a pretty good measure of, like making sure things aren't progressing. New abscesses is tough because abscesses can kind of come and go. So it's really tough if a patient had a 50% improvement because they had a lot of nodules that got better, but they had 1 new abscess compared to baseline. So the AN 50 is just another way to look at things, another outcome we use. So if you look at the simulation here, you can see the number of lesions, and basically here's a 50% reduction. So not clear, but 50% better. And so when we look at this, the AN 50 at week 16, that primary endpoint in Sunrise and Sunshine, we see over 50% of patients are achieving that AN 50, a 50% reduction. And this was in the Q4 week group, that typical psoriasis dosing that we know. And this is extending it out to 1 year or 52 weeks. So we see in the 2 groups that started on COSENTYX, and then the groups that started on placebo and then switched over and were re-randomized, about 71% of patients on COSENTYX had improvements in abscess and inflammatory nodules at 1 year. So it's just another measure of disease and another way to show that it responded and things did well. Again, this is as observed data, so there is always a chance that some of these people who didn't make it to the 52-week for whatever reason didn't count against the total. So there's always a chance that there could be a little enhancement of the data. But I always also say that that's sort of real world data. If a patient decides that they're not going to continue the drug, you're not going to keep them on it to week 52 just to see what happens. But in the patients who are responding, you can see that they continue to respond. And then let's talk about the other exploratory endpoint of flare. So was it able to reduce flares at week 16? The definition of flare for clinical trial is a 25% or greater increase in that AN count or abscess nodule count, and a minimum increase of at least 2 over the baseline. So we kind of have done some work in trying to define what does flare mean. It can mean something different for patients who might have their own way of defining what is a flare-up. And then it's hard because flare can also be relative to the treatment response you're seeing. If you start to see improvement, at least in a patient's eyes, you start to see improvement and then a little bump, they might call that a flare. But for a trial, we really need a clear definition of what a flare is. So they defined it as a 25% or greater increase and at least 2 lesions above the baseline. So using that definition in the Q4 week arm for COSENTYX, we see just over 75% of patients having no flares, no worsening above their baseline, at least 25%. So that's an important thing to talk to patients about because they worry about flares. And I usually am counseling patients that, don't give up on a treatment if you do have what they consider a flare. But it's also kind of important to note that for the trial, it's defined as above baseline. And then about 78% had 0 flares at in the Sunrise trial at 1 year. So that's a pretty impressive number, because with a disease that kind of goes up and down and waxes and wanes, flares can happen. So it's nice to know that these patients who responded didn't have a lot of periods where all of a sudden things were worse than they ever were, and then they got better again, which is sort of what I counsel my patients is what we expect to see from a treatment for HS. I expect to see sort of a steady improvement in the right direction. It doesn't mean it's going to clear you up right away and you're never going to have another spot, but in general, your flares are not going to be as bad as they were, which again speaks to that, not going above that baseline by 25%. And then the pain. The thing that patients really care about is relief of their pain. So the reduction in the skin pain at week 16 happened and was carried through 1 year with continued observed reductions during that time. And about 70% of patients with moderate to severe skin pain at baseline had mild or no pain at 1 year. So getting patients who had moderate to severe pain down to mild or no pain at a year is very clinically meaningful. You can tell patients it's going to get, most patients saw a reduction to mild to no pain. That's something they can understand and they can appreciate. In terms of quality of life, this was as observed data from the DLQI, that Dermatology Life Quality Index. And it's a questionnaire that has a series of questions that sort of asks you about leisure activities, your symptoms, your feelings, your personal relationships. This trial was for adult patients, but they have adjusted DLQIs for adolescent patients, because sometimes the DLQI, or for adults, the DLQI will ask about things like intimacy that you may not want to ask an adolescent. But it's a very good measure of how your skin disease affects your daily life and prevents you from doing the things that make you happy and the things that you love. So for the trial, the quality of life improvement was defined as at least a 5-point reduction in the DLQI. Higher numbers are worse, lower numbers are good. So DLQI, if you can get it down to 0 or 1, patients are doing, or 0 to 3, patients are doing really great. What's interesting is that typically the definition of a clinically meaningful improvement in DLQI is a 4-point reduction. So they actually went 1 higher and said, we want to see a 5-point reduction. So that's beyond the typical definition of what we say as clinically meaningful, which means it's really clinically meaningful. So you can see at 16 weeks, hitting that measure of reducing the impact by at least 5 points was seen in 42 to 47% of patients, and then extending the data out to 1 year, it's between 47 and 53% of patients were having that 5-point clinically meaningful significant reduction in their DLQI. Again, you can't compare that. There was no statistical analysis performed on this because it was an exploratory endpoint. But those numbers are impressive and very meaningful to patients. So we also, I kind of mentioned a little bit earlier about this week 2 data. So we saw the reduction in the number of inflammatory nodules and abscesses by half, or that AN50, with no new increase in draining tunnels, which is that the high score 50. And then we saw 71% had at least a 50% improvement from baseline in their inflammatory abscess and nodule count at 1 year. 83% had no new tunnels. 78% didn't have any flare-ups at a year, and 70% who started with that moderate to severe pain had no pain to mild pain, and patients had improvements that were meaningful in their health-related quality of life at 1 year. And then, of course, we always have to talk about safety. It's always a good conversation to have with patients, and HS patients in particular, as you've probably experienced, often have a understandable mistrust of the medical system. Like I mentioned earlier, they've seen a bunch of doctors who didn't even know what they had. They've been told it was an infection or due to obesity or poor hygiene. They've been given treatments that don't work. Then just to have doctors throw their hands up and go, I can't help you, sorry, you have to see somebody else. Or, you know what, this disease, you just have to wait till it gets really bad and then they'll cut out your armpit and that's the only treatment. So these patients have sort of heard a lot of myths and misinformation that really causes them to mistrust. And really, when they're coming in to see you in your office, it's good to sort of remember that they're really sort of on a first date with you at that first visit. They're trying to test, like, do you even know anything about this disease? Are you going to be able to help me? Have you heard of this? Do you know what I have? Do you know what you're talking about? And unfortunately, it's because so many healthcare providers they've seen before you didn't know anything about it. So that's why it's really important to talk about the safety data, because patients can have this sort of understandable mistrust, and that makes it harder to convince certain patients that they need to, you know, sort of trust you. And it's nice to be equipped with the safety data to say, hey, this is a safe drug. We know a lot about it. We have experience with it, and I'm going to have this conversation. So the good news is, if you're used to giving COSENTYX for psoriasis, safety profile is about the same. We didn't see any new signals with our HS trials. So you can see the rate of any adverse event was about 65-ish%, but there were no deaths. And then when you go down to the number of people who discontinued the study treatments to adverse events, it was very low. This is like the actual raw numbers, you know, 1, 5 in the placebo, 1 in the placebo and Sunrise, 4. And then there's certain things we look for. So we know with anything that modulates the immune system, we're looking at those infections and infestations. Of course, URI is always at the top of the list. You do a trial for 16 weeks or even for 52 weeks, and this is the 16-week data, people are going to catch colds. So we see it, you know, people catch colds. It happens in the placebo group. It happens in the COSENTYX group. If you aren't familiar with the FDA's approval in clinical trials, for a side effect to be listed for a medication by the FDA, there has to happen in at least 1% of trial participants and more in the placebo or in the treatment group than the placebo group. So if it's 1.1% in the treatment group and 1% in the placebo group, that'll get listed. So that's why sometimes you look at the numbers and go, these don't look like there's a statistically significant difference between groups, but that's because you don't do statistics on these as a rule. That's just the rule for defining adverse events in clinical trials for approval. We did look at fungal infections because we know the IL-17 pathway is involved with fighting Candida. So there is a small risk of Candida infections. They could typically be treated with either a topical therapy, if it was thrush, maybe nystatin, swish and spit, or a dose of fluconazole. And most patients, it was a one-time event. They didn't have secondary recurrence of the infections. So it wasn't a major issue. It is something I will bring up with patients, mostly because they're used to having a skin disease that sort of looks like an infection. So I might mention what thrush looks like or what a yeast infection can look like, just so patients can kind of have it on their radar and not chalk it up to, oh, this is just my HS looking a different weird way. And then hypersensitivity reactions can happen with any kind of medication. So of course, if the patient has one, you're not going to continue. And then we looked at malignancies, MACE, new onset IBD, and the good news is we're not seeing any signals there, which is the safety data that we're used to with COSENTYX. Extending it out to a year, the big take-home message here is that we're not seeing any new signals out to a year. I think we're all pretty used to now looking at this more long-term safety data to make sure that the longer you're on a medication, we don't see any kind of new safety signals emerge. And it's an important thing for patients. You know, that's one of the beauties of this drug being approved for other indications, including psoriasis, for a while, is that it's not brand new. And you can kind of help patients who are a little nervous about new medications and the potential idea that something might come up later to say, hey, this is new for your disease, but it's been around and we have a track record of safety. And so one of the things that sometimes comes up with IL-17 is new onset inflammatory bowel disease. And it's kind of an interesting conversation when we talk about inflammatory bowel disease and IL-17s, because it sort of came up as something that people were like, oh, does this, you know, what's going on with this? And we see in the Sinai trials, there was a less than 0.3% incidence of new onset inflammatory bowel disease with COSENTYX. What's really interesting is we talk about these rates and you go, oh, well, 0.3%, that's not zero, but the prevalence of IBD in the general population is 1.3%. And in patients with HS, there is a known association with inflammatory bowel disease. And we know some of these pathways are similar. And that's why, for example, TNF inhibitors, if you're treating rheumatoid arthritis, you might see new IBD or psoriasis or HS pop up, those sort of paradoxical reactions where we block part of the pathway and then something else pops up. So we know from epidemiological data that HS is associated with inflammatory bowel disease. So patients with HS have a 3.3% prevalence of inflammatory bowel disease. So while the prevalence isn't zero in patients who were treated, we know that it's also not zero in patients with HS. So it's got a well-studied clinical profile, no boxed warning, no suicidal ideation and behavior warning, which we know has arisen with other IL-17 inhibitors. The only required routine lab monitoring is a TB test prior to starting therapy. You don't even have to, it's not on the label to repeat that TB test. And that's been sort of an evolution in thought where these TNF inhibitors really raise our awareness of the risk of reactivation of latent TB in patients. But as we saw, as we've learned more about IL-17, it's not really involved in forming granulomas and fighting tuberculosis. So it makes sense that we're not seeing that same risk in this class. So it is still important to screen ahead of time because you are modulating the immune system, but it's just that baseline screening required. And then there's no trend toward an increased incidence of inflammatory bowel disease, candida infections, MACE, or malignancy through year 5. So that's a really good thing that we're not seeing any new safety signals. We're not seeing these trends toward increased incidence of these other problems. There are important considerations for safety. So it may increase the risk of infections, which is nice when the label says something may increase the risk of infection instead of does increase the risk. If patients are particularly worried, sometimes I point out that verbiage. A higher rate was seen in patients treated with COSENTYX compared to placebo. And we see that sort of the typical things like nasopharyngitis, upper respiratory tract colds, and mucocutaneous candida infections. And then, like we said, it is possible to have more serious infections. So especially if a patient does have an infection in the beginning, you want to take care of it before you consider treatment, or if someone has chronic and recurrent infections. And then, as I mentioned on the last slide, you want to evaluate for tuberculosis ahead of time before starting, so you know that the patient does not have tuberculosis. Inflammatory bowel disease is something that we sort of bring up, and we say, there have been exacerbations or new onset in patients who were treated with them. But again, I sort of have that conversation relative to the risk of inflammatory bowel disease with HS itself, so that patients kind of understand the overall picture. And then you want to be careful if patients have inflammatory bowel disease and you're considering COSENTYX, and then monitor for signs and symptoms of IBD for patients who you do treat. Eczematous eruptions can happen. It's kind of a difficult thing because HS itself can also kind of cause some irritation and eczematous eruptions, but there were some cases of eczematous eruptions, including these things that look like atopic dermatitis or dyshydrotic and even erythroderma. So the good news is that patients are seeing you, the dermatologist, who is very well equipped to treat eczematous eruptions, but it is something to just keep on your radar. And then you can, if they have a severe eczematous eruption, discontinue, but others were treated and maintained on therapy successfully because we're derms. We know how to treat a little eczematous eruption. Of course, if someone has a hypersensitivity reaction like anaphylaxis, you're not going to continue. COSENTYX, you're going to stop it. And the caps do contain natural rubber latex, so that's a consideration in latex sensitive individuals. And then prior to starting COSENTYX, you should get your immunizations, and it may alter your immune response to live vaccines. So if possible, avoid the use of live vaccines, which is sort of a standard precaution we're taking when modulating the immune system. Fortunately for us, there aren't too many live vaccines out there. The zoster vaccine is no longer live, and the non-live one works even better. But it's something to consult with an ID doctor if they're doing any kind of exotic travel that might require special vaccines. And then again, the most common side effects, nasopharyngitis, some diarrhea, upper respiratory tract infections, sort of the things that we see popping up in clinical trials. So getting started on COSENTYX, you can start your appropriate patients with the UNO Ready pen. So for a long time, we've had the COSENTYX 300 milligrams in 2 150 milligram syringes. That is still available, but now we're going to have the UNO Ready pen, where it's just one injection that contains all 300 milligrams. You're going to start with that weekly dosing for 5 weeks, just like we're used to with psoriasis. And it's just one injection now, and then you can switch to that maintenance dosing of every 4 weeks. So in the trials, we studied both Q4 weeks and Q2 weeks. So the recommended starting dose is weekly for 5, and then switch to the Q4 week. And then if a patient is not having an adequate response, you can consider increasing to the Q2 week data or dosing. So that's also approved based on the data that's available. The good news is in the labeling, there's some flexibility to allow your judgment for when to do that. I think we all, when we see our HS patients, have sort of a feel for their trajectory of their disease, and we're hoping to stop it from sort of a negative trajectory and getting worse. So it's up to your discretion when you sort of make that call. And I think it is based a lot on, is my patient continuing to improve? And I think there's still room where they can stay on this dose and improve, or does it seem like they're starting to plateau or not responding as well as I'd like? Am I still concerned? Let me increase that dose. We do have data from the trial that you can see a response to the initial treatment as early as 2 weeks. So it's at your discretion when you're going to sort of make that call. It's going to be a case-by-case basis, what's best for that patient. So here again is that nice new Uno Ready pen, the 300 milligrams in a single injection. The cap is not made from natural rubber latex, and then it's convenient and positive. 98% of patients reported no pain at the injection site in a study with psoriasis. So that's kind of nice that, that's always a concern for patients when they're using an injectable is, how much does it hurt? Like I said, the existing dosing is still available. Because of the way that it works in the United States, the NDC number is different for the Uno Ready pen and for the currently available pens. So patients won't just automatically be switched. You'll have to switch over. There is a possibility that it might require a new prior authorization depending on how your insurances have updated their formularies so if they recognize it's the same drug, or if that's something you'll have to sort of help them understand and teach them. So your existing patients can kind of stay on what they're on and won't automatically be switched, but when you see someone back, you may consider changing. Or for your HS patients, the beauty of this coming out with the approval for HS is that you'll be able to start them on this dose, this pen right away. So that way they just have to do the 1 pen per dose, which is more convenient and, reduces the number of injections by half. So it's covered as first or second line biologic for HS on private insurance, Medicaid, Medicare. That's one of the, again, beauties of a medication that's not new to the market, is already available and just has an expanded indication, is that it's already on formularies. Insurance companies already know what it is. So it's just a matter of sort of changing their coverage criteria and expanding their indications versus sort of them learning all about a new drug and you waiting for their formulary to be updated. About 80% of commercially insured patients have coverage for COSENTYX as a first-line biologic, and Novartis is sort of here to help with that. They have their Covered Until You're Covered program where patients can get the drug for up to 2 years. So if you are sort of having those insurance struggles and trying to figure things out, it buys you the time for the insurance to sort of catch up, figure things out, and it bridges patients to being covered so they don't have to wait for all of that issues to go through. For privately insured patients, they may be eligible to have as little as a $0 copay, which is more convenient for patients who do have sort of tiered copay or may have trouble. And about 94% of patients with the COSENTYX $0 copay paid nothing out of pocket. And then there's the COSENTYX Connect team, where members can help patients get started, navigate insurance, understand savings options for injection resources. So it's really nice to connect your patients with the COSENTYX Connect team. So that way, if after hours they have a question about, I'm packing for a vacation, what do I do? How do I handle this? And then they have other resources like a welcome kit that includes a sharps container, some educational resources, a travel bag, things that patients need when they're starting a biologic therapy. And they have access and reimbursement managers, which can help to sort of understand the payer landscape, help your office navigate health plan and coverage processes. So they're willing to come out and talk to the people in your office who help with your prior auths to kind of understand things, and they know the local anatomy of how prior auths go and what coverage is in your area. So again, COSENTYX, it's very exciting to have a second drug and a first IL-17 inhibitor approved for HS. Results can be seen as early as 2 weeks, lasting relief at week 16, and the reduction of inflammatory nodules and abscesses as measured by that high score. Trust in a well-studied clinical profile, and it's covered on private insurance, Medicaid, and Medicare. So it can really help patients out, and you can go to COSENTYX healthcareprovider.com for more information. And now I'm happy to take any questions, and thank you all for joining. Thank you all for going the extra mile to take care of HS patients. It's so great that our patients can get access to expert dermatology care and have treatment options.
Thank you, Dr. Daveluy. This was a great presentation. I really, truly enjoyed it. It really is great to have new options for our HS patients. It is a disease that we really don't have much for, and has been a frustrating disease for our patients, and for us, of course, for our patients a lot more. I do have a couple of questions that came through the channels. One of them, which is interesting because I get this question quite a bit about myself in multiple stages, but if you need a live vaccine, how long should you wait after the injection to get the vaccine? Or how do you deal with your patients who need live vaccines who are on something like COSENTYX?
It's a great question, and we don't have any strong data, so we've tried to extrapolate some things from other disease states and other immune modulators. A lot of people will say 2 to 3 half-lives, which can be a little challenging when you have a medication that maybe you're giving every 4 weeks. So some experts will say, you know, skip a dose, get the vaccine when your dose was due, and then wait until the next dose, so sort of a 4-week window on each side. But it's kind of a conversation to have with your patients, because it may depend a little bit on the severity of their disease and are they ready to sort of take a break. But it's tough because there's not a lot of solid data. One reassuring thing is there's not a lot of reports of there being problems with live vaccines, but it's still something you don't want to just be cavalier about. So that's generally sort of what I'll do with my experience, is maybe say wait, sort of like miss a dose and get the vaccine instead of the dose. But like I said, there's no hard and fast data to sort of guide us. Usually if they're getting one of those live vaccines, you can always call an ID colleague and like glean a little help from them too.
Correct. I usually do that, and they don't seem to know much more than me what to do with it. When that happens, it's kind of what we decide to do together. Another question: who is your HS COSENTYX patient? When do you decide it's time to get them on COSENTYX?
That's a great question. So anyone who is sort of biologic eligible, which that's a very interesting conversation, because there is data that we are probably patients who are eligible for biologics in HS are being vastly undertreated. We know even in psoriasis, patients are getting undertreated. In HS, we think about 66% of patients are biologic eligible, and one study showed that about 1% are actually being prescribed one. And I think in HS, it's a much more dire need to treat patients. We sometimes talk about this window of opportunity where they get diagnosed and the disease is getting worse. Even before diagnosis, the disease is getting worse and worse. They get diagnosed, they get treated. So hopefully all of us are sort of willing to sort of look at patients and say, what's the trajectory of this disease? Even if it's still on, you know, the early moderate side, are they responding to any treatments? Are they sort of progressing? Is there damage being done? Is it already forming tunnels? So sometimes I parallel it with nodulocystic acne, where you go, well, they're already getting acne scars, so this kind of bumps you up into a more severe category. So definitely if patients are starting to form tunnels, I think that's a time where you need to consider long-term therapy with a biologic, possibly with a systemic. We don't have as much robust data with systemics. We don't have as many randomized controlled trials, and they're smaller numbers for something, say, like spironolactone. That's very early data. We don't even have randomized trials for it. So I think forming tunnels is a good reason. And like I said, that's sort of that trajectory that the patient's on. And of course, our patients who are already early stage 2 or 3. In terms of sort of selecting my biologic, sometimes it comes down to comorbidities, side effects. If patients have a history of malignancy, you're going to want to avoid the TNF inhibitors. If they have congestive heart failure, especially if severe, that can lead to complications from TNF inhibitors. The IL-17s are more favorable. Maybe if they have a history of inflammatory bowel disease, I'm going to reach for the TNF first because it's got data to support treating both. As we saw though, if you're really in a pinch, you can treat a patient with inflammatory bowel disease. They weren't included in the trials, so we don't really have data in that sense. But if you're running out of options, the risk is, as we saw, somewhat low. But those are some of the things that go into choosing it. But that's kind of the big message that we're really trying to encourage people, is that you sort of need to consider what's going to happen to this patient down the road. What's the trajectory of where they're going, to make sure we're not sort of delaying treatment and allowing the disease to progress and get worse.
Okay. And, we're running on time, but last question, what baseline labs do you do for your patient with COSENTYX?
So I actually just do the tuberculosis test. I know a lot of people will still maybe check a CBC. I do, if they haven't had it recently. I'll also check hepatitis B and C and possibly HIV. There were no signals for those, but I just like to know a patient's overall immune status, and I'm sort of used to doing it for our TNF inhibitors too. Plus, it's a good idea for everybody of a certain age to be screened for hepatitis C, and everybody who's sexually active to be screened for HIV. So might be that point in the healthcare system where people can get their screening. But I'm comfortable by and large just doing that TB test because we didn't really see other lab abnormalities that sort of warranted monitoring anything else. And I just do it at baseline because we really know IL-17 inhibition isn't involved in fighting tuberculosis.
Okay. Well, Dr. Daveluy, this was absolutely great. Thank you so much for being here with us today. Thank you also for Novartis for being the sponsor of this event. It's absolutely been great. And we will see all of you guys in the next one. Thank you.
Thanks so much for having me. Thanks for attending, everyone.